Wonderful to have you with us, Kate, and I'll turn it over to you to lead our program for today.
Thank you very much. And I apologize. Oops, I'm going to need you to enable me to screen share, John, please, if you're the host.
So you should be good, Kate. I just switched it.
Okay. I apologize for the speed of my internet. I live in Shoreham and I have absolutely terrible internet. So I'm hoping, and I had to come through the VDI, through the Blue Cross website to be able to do this, sorry, through our desktop at work. So please let me know. I asked Rebecca Copans, who's on here, to let me know if I'm fading in and out or if this isn't working. So I apologize in advance for any technical difficulty. I wanted to have a chance to talk to you about COVID. Thank you so much for asking me. I'm really here for you guys. I cannot see the chat, but I will stop throughout this to answer questions. And then if someone can help me by reading the chat questions, I will answer all the questions I can. I apologize, this is a little bit longer than I had intended, but I wanted to put information in here about the vaccine. And so it ended up being slightly longer than I had originally planned. The glass sculpture that you're looking at is a model of coronavirus. This is the SARS-CoV-19 that is causing us so much trouble. But I think that the sculpture here is remarkably beautiful. So I wanted to start a little bit by talking about trends and clinical updates. This is the kind of information that I have been giving to Blue Cross on a regular basis. All of these graphs that you're going to see here are available on the Vermont Department of Health website. And I encourage you to check out the dashboard if you haven't already. The cumulative cases by date here on the left show you how many total cases we've had in the state of Vermont. And that graph, as you see it, this is about a week old, but it is continuing to climb. The different colors that you are seeing on this graph are the different counties. And so there's a lot of really good information on the website. I encourage you to check out the dashboard. It is a little bit tricky. The standard dashboard that everyone looks at, there are arrows at the bottom and you can flip through and they have different types of maps. This is one of those maps. On the right-hand side, what you're going to see is also on the Vermont Department of Health website. They have recently changed this township map to show the number of active cases by town in the last 2 weeks. They update this every day, or they update the graph on the left every day, the graph on the right, they update weekly. And it's also very helpful. It can show you exactly what is going on in your township in terms of active cases, which can help you guide your activities. They also have a graph that looks like this. These are the updates in the outbreaks and trends that are happening. This shows you daily cases, again, listed by township or by county. The dark blue is Chittenden County. The green is Washington County. The light blue is Addison County. So you can look at this and see what's happening on a county by county basis on the health department website. And again, this is updated daily. So I highly recommend that you go take a peek at it. So we're going to talk about COVID, and I wanted to talk about the sort of what's called the Swiss cheese model of protection. So the reality of infectious disease is that infectious disease doesn't respect any particular boundaries. And it's very hard to find any given thing that is 100% effective against an infectious disease. And so very often we rely on a series of different types of protection to try to keep people safe. So staying home if you're sick is not great. I mean, we know this in schools, right? They send kids home from daycare when they're sick, and it doesn't work. Kids get sick at daycare all the time anyway. But it's a piece of what can help. Wearing a mask is a piece of something that can help. Is it 100%? Absolutely not. Does it work? No, not 100%. Does it work some? Yes, it does. Washing your hands, covering your mouth when you cough, does that help? Yes. But is it 100%? No, absolutely not. Does not touching your face help? Yes. Is it 100%? No. But when you start to stack these up like slices of cheese, even if there are holes in them, at some point, you're going to block the infection. And so all of the things that are on this graph are steps that can help prevent infection. And that's why all of them are important, not just one, not just two, but all of them, because it's what keeps the virus from moving, if at all possible. And you'll see on this, tracing and testing is important, and we're going to talk about that. Ventilation, staying outdoors, air filtration, quarantine and isolation, we're going to talk about that, and we're going to talk about vaccines. Are there any questions about this model? John, anything in the chat yet?
I'm seeing nothing so far. Onward.
Okay. All right. So I want to talk quickly about, and I hope this is, apologize for the slowness of the slides changing. I want to talk about diagnostic testing because there's been a lot of questions about testing. There are two types of diagnostic testing to look for active infection. I'm not going to talk about antibody testing. Antibody testing answers the question, have I gotten the virus in the past? And we're not going to talk about that today. We're only talking about active infection. Do I have disease right now? And there are two types of testing. There is what is called reverse transcription polymerase chain reaction. This is called RT-PCR or PCR testing. And there's antigen detection, diagnostic or screening testing. And these are the rapid antigen tests, the ones that are being given at the airport, the ones that you've heard about from other places, the quick turnaround 15-minute tests. These are the two types of tests that are available for diagnosing whether you have active COVID infection. And we're going to talk about them because they're very different. So one of the things that is hard to understand sometimes, but very important, is that the accuracy of a test changes depending on the density of the infection. So depending on where you are, your test is going to have varying degrees of accuracy. So if you test people in a nursing home setting where you know there's an outbreak and people are very likely to have the disease, and they test negative, it's possible that you're missing an infection. So if you're testing people who are likely to have the disease, they're in a nursing home, they're coughing, they look symptomatic, and they test negative, they're still likely to have that disease even though the test is negative. That's what we call a missed infection. On the other hand, if you test people who are very likely not to have the disease, like, for example, somebody who's flown in from Cleveland to the airport and is getting a test in the airport but has absolutely no symptoms and is not at risk, they're still likely to not have the disease even if the test comes up positive, and we call that a false alarm. The result of this is that it can make testing very complicated because you can't assume that the test is accurate outside of the context in which the test is given. So you always have to be asking the question, not just what did the test say, but do I believe what the test said? And that makes testing in areas of low density of infection very complicated because no test is perfect. And we're going to talk a little bit about this and about why it makes different types of testing complicated. So the PCR testing is the recommended test of choice in all settings across the board. If you have a choice about getting a test, get a PCR test. They are more accurate in every setting, in settings of high risk of infection and in settings of low risk of infection. But there's a lot of muttering about these rapid antigen tests. And I want to talk about them very specifically because they're complicated and they're not for everyone. The Vermont Department of Health has started antigen testing in nursing homes, but they are not recommending antigen testing for anyone outside of nursing homes. And this includes urgent care centers. It includes work centers like grocery stores or schools. And it also includes airport testing, anything like that. The Vermont Department of Health does not recommend antigen testing for people who have no symptoms, does not recommend it for employment settings, and does not recommend it for anyone outside of nursing homes. So if you're outside of a nursing home and you have to be tested, try to get a PCR test because it is a better test. Now, they updated the antigen testing, and I want to talk about this a little bit because it talks a little bit about what I'm saying about how, depending on the situation that you're in, the test may or may not be accurate. So let's talk about the the antigen testing, now this is not PCR testing. What I've said is if you can get a PCR test, get a PCR test. But if you're looking at antigen testing, let's talk about what happens. Let's follow this down because this tells you a lot about how tests work and their test probability. So remember what I said, if you have symptoms on the right-hand side and we follow the right-hand side of this chain down and you have a high prevalence or test probability, then if you get a positive, you can probably believe it. But if you get a negative, you might not be able to, and you should get a PCR backup. On the other hand, even if you have symptoms, let's say that you're at home and you have a cough and you go get a rapid test. If you haven't been around anybody that has COVID and you've been, you've just been sort of hanging out at home and, maybe your kids are in school, but nobody that you know of has been exposed to COVID. If you get a positive, you can't necessarily trust that because you're coming out of a low prevalence area. And so therefore you have to have a backup with PCR. On the other side of the graph over on the left, if you have no symptoms at all and you're asymptomatic and you have no known exposure, we're going down the far right side, and you fly in from Cleveland, you have no symptoms and you have no known exposure. If you get a positive, you can't necessarily believe it, and that should be confirmed with PCR. Now, here's the challenge to antigen testing. The manufacturer says every negative should be backed up with PCR. So now you've got a situation where you've got somebody who's asymptomatic, they have no known exposure, they got an antigen test. If they have a negative, the manufacturer says you should get a PCR test. And if you have a positive, the health department says you should have a positive test. Well, if you have to have a PCR test for a negative and for a positive, why are you getting the test? And this is the place that it's really important to understand. And this is why the health department says, if you can get a PCR test, get a PCR test, because the antigen test is complicated, and this is why. So I'm going to pause there and answer any questions that might have come up, because there's been a lot of question about these rapid tests.
Here's a quick question for you. Is your sense, I suspect a lot of Vermonters when they go get a test may have no idea whether they're getting a PCR or an antigen test. Is there a way for any of us who have been tested to sort of retroactively know? Is it administered differently? How would we know the difference?
A rapid test, an antigen test is a rapid test that turns around in 15 to 20 minutes. If it took 2 days to come back, it was a PCR test. And the primary thing that people say is, well, I want to know right away. I understand wanting to know right away, but you really want to know for sure. And the problem with the antigen test is it doesn't necessarily tell you for sure, whereas the PCR does. So it becomes a challenge of waiting longer for a much more accurate answer, or waiting a shorter time for an answer that may in fact be wrong. And that's why the antigen testing is so controversial, and why the health department doesn't recommend it, except in settings like nursing homes. And I understand in nursing homes why they do it, right? It makes perfect sense. If you have an outbreak in a nursing home and you have to decide who to put on what floor to try to isolate them, you need an answer in 15 minutes, even if it isn't an accurate answer. And so you're going to use that information in the next 15 minutes to make decisions. But all of those antigen tests are being backed up by PCR to answer the question, was I right? Was this test accurate? So they're being used in controlled settings where the knowledge is going to make a difference within 15 minutes. That's a very different setting than going to an urgent care to say, I just want to be tested, or, I came home from Massachusetts and I've quarantined for 7 days and I just want to know if I'm positive or not. That's a very different setting than what we're talking about in nursing homes. And that's why they're using it in the nursing home, but not in the, not recommending it in the community setting.
And a follow-on question from Jenna here, which said that VPR recently had a story about tests that are available at drugstores. Are those, do you know if those are antigen tests? Are those sort of ideal or not particularly useful?
So the drugstores are doing both. Many of them are doing both, and you just have to ask which is which. And generally, I think that the drugstores are doing PCR testing, not antigen testing, but you just have to ask which one. Again, if you're getting it back in 20 minutes, it's probably not the test you want. If it's going to take several days, it's going to be the test that you want.
So this is certainly a situation where we as consumers, it's good to just be aware of this. You know, one other follow-on question, is there a difference in pricing or availability between these two in Vermont?
So the antigen test is less expensive. The PCR test is more expensive, but we want you to get the more expensive test, and they both are covered at 100% under the CARES Act from the federal government. Now, the antigen tests that are being done at places like the airport, people are having to pay out of pocket and then submit a claim. Most of the PCR testing is being submitted directly to us as a claim, and those are getting paid at zero cost share. So, but the CARES Act from the federal government says that all testing has to be covered at zero cost share to the patient. So you shouldn't end up having, at least if it's done because you're sick. If it's being done in an employment setting, those are not mandated for coverage by the federal government. But if they're being done to answer the question, you know, am I sick? Do I have COVID? As opposed to screening at a college or screening in a place of business or screening in a school, those, if they're submitted as a claim to the insurance companies, should be getting paid.
Great.
If they're being done as screening for employment, that's a different issue. Those are not covered under the CARES Act, and you may end up paying for those.
I think we've got our questions answered, so onward.
Yeah, so and I'll give you an example. So colleges, a lot of the colleges, my son went off to college this fall, and the college screening, that's not covered by insurance. Those you have to pay, we ended up paying for. So I want to talk about, I'm going to get a little bit scientific here and talk about a variable called RT, because you're going to hear this word floating around. It was floating around for a while when we were really particularly bad. If anybody's really interested in how COVID is transmitting in different states, this comes off of a website called rt.live, which will give you up-to-date information on COVID-19 transmission around the country. So what is the R coefficient? The R coefficient is how contagious is a disease. And there are two variables to R, to the R coefficient. One is called R0, and that means in a completely uncontrolled setting, if you catch, for example, measles, how many people are you likely to spread it to? Or if you catch the flu, how many people are you likely to spread it to? Every virus has an R0 value. That R0 or R0, as it's sometimes called, varies a lot. So for the flu, the R0 is about 2.5. For the measles, the R0 is 25. One person with measles is likely to spread it to an average of 25 people. For COVID, uncontrolled, the R0 is considered to be approximately 3 to 3.5. There's another R coefficient, which is the one that's on this slide, called the RT. So the R0 is the wild, sort of the uncontrolled experiment. How much do you spread something? The RT is, given social distancing and masks and, you know, shutting down restaurants or any of the other controls that we've put on schools with screens and plexiglass and putting people 6 feet apart, with all of the measures that we're taking at a given point in time, that is the T for time, how contagious is COVID? So what is the contagion factor, the R, at a point in time, given the measures that have been placed within a state? And what this shows you is what the RTs were for this particular moment in time for all of the states in the country. And the reason this matters is this. So number one is very significant. What that means is that if the RT is 1, every person infected with COVID is going to infect on average one other person. If your RT is greater than 1, your outbreak is going to continue. If your RT is less than 1, that means that everybody with COVID is going to infect less than one person, and your outbreak is gradually going to go away. So getting that R below 1 stops the virus from spreading as quickly and makes it gradually burn out. Any R greater than 1 means that you're going to continue to get a rising number of infections. And our RT has been varying a lot. There was a period a couple of weeks ago where it was one of the highest in the country. Then it got knocked down, actually very close to 1. Now it's back up and it bounces all over the place. But the goal is to get that RT below 1. And that's where all of these measures that the Scott administration is taking, that people's personal responsibility is taking, is trying to do. We're trying to knock that RT down below 1 so that our number of cases starts to go down. And so you can monitor it in real time on this website. So this basically reiterates what I had said. The RT is the transmissibility of the virus. It's how easily it goes from one person to another. If it's 1, it means that every person infected with the virus infects on average 1 other person. If it's greater than 1, the virus is going to increase in your community. If it's less than 1, the virus is going to decrease in your community. If it stays at 1, the virus is going to continue to have the same number of active cases in your community that it's had before. So it's a very important concept that the health department is thinking about. All right, before I go on to quarantine, let's talk about RT. Are there questions, John, about transmissibility?
Here's a question for you. Do you feel like so as the Department of Health considers what limitations we are living under, is this really the number they're thinking about? In other words, sort of we're striving for a number under 1, and we allow for certain amount of, let's say, human contact if they feel like the modeling shows that we're going to stay under that 1 RT value. Is that sort of what's driving decision making at the health department?
I'm not in the health department, but I think that is basically where they're going. And what they're doing is they're trying to be even more granular. What they're saying is the RT is less than 1 in schools, so let's keep the schools open. But the RT is greater than 1 in bars, so let's close the bars. The RT has been greater than 1 in small group gatherings, but it's less than 1 in restaurants. So they're trying to be extremely granular about where the places that increased transmission is occurring to try to keep as much open as possible, while simultaneously realizing that we do not want this RT to get out of control. And the reason that they acted when they did was because our RT was 1.43, which was the highest in the country, which meant that even though we didn't have a lot of cases, we were rising faster than any other state. And that's when they got really concerned and made the moves that they made about 4 weeks ago. And it's worked because it has brought our RT down, but we're still not under 1.
Great, thank you.
But the goal is to get that RT under 1, and it takes all of us to do that. So speaking of getting the RT, let's talk about quarantine. So quarantining, we're going to talk about what it is, and then we're going to talk about how to do it. And the reason for quarantine is specifically has to do with that transmissibility, because you don't want to be the person who then transmits COVID beyond to other people. So who's required to quarantine for 14 days? Well, clearly anyone who's been exposed to COVID-19. But the other is anyone who's traveled out of state for non-essential purposes. And this means all holiday travel. And part of why, the reason for this is that if you look at the maps that are out there that show active cases throughout the country, Vermont is this little bright spot in the middle of a pretty depressing scene in the rest of the country. We are still doing better than the rest of the country, but it won't take much for us to not be doing better. And we've been very responsible and very fortunate, but we are not unique. There's nothing about our biology that exempts us from COVID. We are being successful because we are being careful. And if we stop being careful, we may stop being successful. So anyone who's traveled out of state for non-essential purposes, including all holiday travel, any student returning home for break, any parent who picked up a college student for break. So for example, my son was at school in Philadelphia. I drove down to pick him up. We drove back up here, and my daughter at the same time came back from where she had been staying in Massachusetts because she had been working remotely for her college. And we all quarantined for 14 days. so that we didn't go anywhere, and I had laid in enough food for 14 days before they got back, and we all quarantined because we didn't want to spread it anywhere. And then anyone coming to visit you from out of state has to quarantine as well. So let's talk about what is quarantine. So quarantine means staying home, staying at a home or a dwelling for 14 days. And that's 14 days from the time you were either potentially exposed to COVID or the time you came back from non-essential travel. Quarantine means no grocery shopping, no getting together with family or friends, no leaving the house to go to work, no activities outside the home, no kid goes to daycare, nobody goes to school. And if you have someone in your house in individual quarantine, you have to separate them from everyone else and check them for symptoms. So for example, if you have a child in college in Boston and they have their own car and they come driving home, then if you want the rest of the house to not have to quarantine, they have to stay in a separate spot, preferably with their own bathroom. And you have to sort of leave them food at their door, but they have to remain separate. The minute they mix with your family, you all have to quarantine together. You can't bring someone in and say, oh, they're quarantining, but we're all eating dinner together. That isn't quarantine, and that doesn't work. You have, if you're being exposed and that person's being exposed, you all have to quarantine at the same time. So it's onerous. Having just done it, it's onerous. It's a pain, but it's also really important to try to check the spread of COVID-19. So if you have someone quarantining in your house as an individual, as I said, they cannot mingle. They can't be allowed in the rest of the house. They need to stay in their room or in their part of the house. They should have their own bedroom and bathroom if possible. And you should, if you can, wear masks in the house and prepare their food for them and have them eat separately. It's not fun, but it's critically important. If you are quarantining as a household, because you cannot make them quarantine. Let's say that the child that was exposed to COVID is a kindergartner. Well, you can't shut them in a room for 14 days. That's not fair. So if you can't keep that person separate, they're not a college student, you can't, they're too young, you can't reason with them, or as a family, you're not willing to do that, then you as the whole family have to quarantine. And that means nobody goes to work outside the home, nobody goes grocery shopping, no one goes into town. It's a pain. It's an absolute pain. You have to, call your friends and you're like, we're out of eggs. Can you please drop eggs off on our porch? It's a pain, but it's really important. This is how you slow transmission. So if you quarantine in the whole house as well, let's say you have family who say, we're coming for Christmas. We don't care what you think, we're coming for Christmas. Then if that family is coming from out of state, this is tricky. One of several things has to happen. If they come from out of state, you either have to complete 14 days of quarantining after they've left, or they have to do a 14-day strict quarantine at home before they come and then drive straight up here without stopping. So it's too late for a family coming for Christmas to do a 14-day strict quarantine before coming up. But I'll give you an example of this. So my parents live in Boston. They are in their 80s. If, say, in February, we decided we wanted to get together and the governor was allowing it, in order to do this, we would have to do the following. They would have to quarantine for 14 days, get all of their groceries delivered, not leave their house, and we would have to do the same thing up here. I would have to go grocery shopping and buy 3 weeks of food. And then we would have to do 14 days of strict quarantine in our house because I don't want to infect my parents. They're high risk. Then they would have to get in their car and drive straight up here. And then we would all stay here in the house and none of us would leave for the time that they were visiting. And then when they left, we wouldn't then have to quarantine because we'd all done that 14-day quarantine plus the 5-day visit. But if somebody comes up and they haven't quarantined, you need to do 14 days of quarantine after they've left. And the quarantine begins after they leave, not after they arrive. And the reason is that they might not be contagious when they arrive. They might not become contagious until right before they leave or any time in the time that they're visiting. And that's what makes this so complicated and so difficult. And you can't rely on testing to feel safe for the holidays. That's the problem, because just because you've tested negative in the morning doesn't mean you aren't going to be positive in the evening. So I'm sure there's questions on that. John, do you want to?
Yeah, we just had one that's a tough one. What if your spouse is an essential worker who has to go out of state for work?
So if your spouse is an essential worker who has to go out of state, then they don't technically have to quarantine when they get back. But you are going to have to, the problem is then it becomes a personal thing about how do you keep yourself safe, right? And you have to make some decisions about how exposed is that person and what do you want to do with them when they do come back. So technically essential workers don't have to, but the reality is the virus doesn't change just because the decision was made that essential workers don't have to quarantine when they come back. It's not as though essential workers have a different biology than the rest of us. So even though the law doesn't say you have to quarantine, you still have to make some decisions based on the biology of the virus about what you're going to do with that person when they come back. I realize that's an unsatisfactory answer.
There's also a question about sort of a shorter quarantine if there is a test with a result.
Correct. So we're going to talk about that.
Oh, you've got that. Okay.
Yep, I'm going to talk about that. Yep. So the reason that we ask people to quarantine for 14 days is because the incubation period can take up to 14 days after you've been exposed to get symptoms or to test positive. So if you look at this slide is on the Vermont Department of Health website. I'm sorry, it's blurry. But the quarantine bar at the top is 14 days because the incubation period, that blue bar, is also 14 days. But down here, this gray bar, this is what you're talking about. This is the optional early release from quarantine if you test negative on or after day 7 and you still don't have symptoms. This is an option, and I think it's on this next slide. Yep, right here. If you are currently under quarantine and you've had no symptoms during the first 7 days of quarantine, you have an option to be tested. The test must be a PCR test, so it has to be the longer one, and you have to have absolutely no symptoms to leave quarantine. But I will warn you that it's not foolproof, and there have been multiple examples of COVID appearing after 7 days in a negative test. So you can do this to leave quarantine, but it's not 100%. You can get tested on day 7, be negative, and break out with symptoms on day 10, 11, or 12. So this is all a matter of weighing the risks and the benefits, because you can still be positive. Testing does not create a sense of safety. That's the thing. Testing tells you whether or not you're sick. You really can't use it effectively to create a sense of safety. I wish you could, but all it does is tell you where you are in that moment in time. It doesn't tell you what's going to happen that night or the next day or the day after that.
So we have a follow-on question then, which is, what about the 14 days of quarantine? Is that relatively foolproof? In other words, have there been examples of an exposure and then more than 14 days later, someone developing symptoms or the virus?
So it really is pretty foolproof. There are a few situations in which it's not, but it's really pretty foolproof. And the reason is this. All right, let's talk about 14 days of quarantine as an individual. If you are an individual and you're doing 14 days of quarantine by yourself, that's foolproof. And the reason is that most people become sick on day 2 to 5. And so if you become sick on day 2 to 5, you're going to know by the end of the 14 days if you've got symptoms and you're sick. But if you're asymptomatic, you're also likely to become contagious on day 2 to 5. But even if you have 0 symptoms, because remember, 45% of people with COVID have no symptoms at all. If you become contagious on day 2 with no symptoms, you will no longer be contagious after day 12, but you're still in quarantine. If you become contagious on day 4 and you have 0 symptoms and you don't know that you have COVID because you have absolutely no symptoms, you will not be contagious by day 14. And so because most people who are contagious but completely asymptomatic will become contagious somewhere between day 2 and day 5, by day 14, if you happen to have developed it, not known it, been contagious, you will no longer be contagious by the end of the 14 days. So if you are by yourself, whether you develop COVID or you do not develop, if you develop COVID symptoms or you do not develop COVID symptoms, by the end of that 14 days, you are not only out of the woods in terms of being sick, you are also out of the woods in terms of passing it on. The challenge comes when you have a group of people quarantining together. And there, it's a little bit trickier because if you have somebody who develops symptoms, they might not actually develop symptoms or become contagious on day 7 until later in the course. And then if they infect the people around them, that becomes more complicated. So there's a hole in the 14-day theory when you're quarantining as a group that says 14 days as a group is okay, but there is the possibility that someone in the house developed it, passed it on, and that someone else in that area will then get infected after the quarantine. And that's what happened at the Shoreham Orchard down here, right down the road from me, when they had someone test positive on day 19. And what happened was somebody developed it but had no symptoms. Nobody knew that that person was positive because they had no symptoms. Then they passed it to someone else. And by the end, it was 19 days when that person showed up with symptoms. So when you're talking about a group, the 14 days is not 100%. It's pretty good. And I think the health department sticks with it because they don't want to be telling everyone to quarantine for 28 days because it would be so overwhelming, nobody would do it. But this is the reason why the health department does not call an outbreak over until they have had 2 cycles of 14 days in which there have been no additional infections. So from a scientific standpoint, that 14 days works perfectly for an individual, not as well for a group. That was a really complicated answer, but I hope it made some sense.
And to further complicate, we've got another question in chat about some revised CDC guidance that maybe shortens the quarantine period to 10 days. I seem to remember this from the last week or so. The CDC seemed to shorten one of the periods. And so is your information reflecting that, or how do those?
Yeah, so mine is not yet reflecting that. So the CDC shortened the quarantine, but they shortened the quarantine for contact. For known contacts, which is different than shortening the quarantine for everybody. So this is where it gets a little tricky. If you go out of state and come back, they still say 14 days because you don't know when you were exposed. If you have a known contact and you know when that person became contagious and when they were diagnosed, then you can end after day 10 without testing if no symptoms have been reported. And the reason for this is that in the episode of a known contact, you have a much more circumscribed time frame and you have much more solid information about exposure. And by the end of 10 days, pretty much everybody who's going to develop symptoms is going to develop symptoms by day 10. And again, in that setting, if you've got a known contact and on day 7 you get a PCR that's negative and you have no symptoms the whole time, then you're okay. But for when you have people coming in from out of state or people with unknown exposures who are quarantining to prevent importing something, the 14 days still stands. And the reason is that you have a very nebulous beginning. And so shortening it to 10 days, it's hard to shorten it to 10 days when the beginning of potential exposure is so nebulous. Does that make sense? So if you have a known exposure, it's a lot tighter on one end, so you can be a lot tighter on the other end. If you have an unknown exposure, they leave it longer because of the uncertainty factor.
I guess that makes sense. Although I will have to, this is speaking for myself, it feels a little counterintuitive where someone who knows they were exposed actually has a shorter time period, whereas someone who has uncertainty and may have had no exposure whatsoever, right? Like that, it feels a little counterintuitive that that person with uncertainty has a longer time period, I guess. Like that.
It does. You're absolutely right. The other thing to remember is it's all, I mean, remember, the biology of the virus hasn't changed. When they moved from 14 days to 10 days, they moved a residual post-quarantine transmission risk from 1% to about 10%. So, you know, when they moved it for convenience purposes, but they didn't change the fundamental biology of the virus. So you can still, with the 10-day quarantine, have an upper limit post-quarantine transmission risk of 10%. Whereas with the 14-day post-quarantine transmission risk, you have an upper limit transmission of about 1%. So what they made, the decision that they made was for convenience, but it does increase the risk that you will in fact transmit it after your quarantine has ended. Because the fundamental biology hasn't changed.
And someone did point out in chat that the Department of Health really hasn't changed their guidance down from 14 days from quarantine. So Vermont seems to be sticking
Vermont
with
hasn't.
Yeah.
So. And I think the reason is this. I mean, we're dealing with an infectious disease. It doesn't care, right? There's no flexibility in what the virus itself does. So when you change guidelines like that, all you're doing is changing risk tolerance. You're not actually changing the biology of the virus. You're just changing how willing you are to take a risk that you're going to get continued spread. And I think what the health department is doing in Vermont is saying, look, we're already better than most of the country. We want to stay that way. And we're going to keep our risk tolerance very narrow. And we're going to keep our 14-day window, because when you go to 10 days, you're changing your risk tolerance. And if you're in South Dakota, where the virus is transmitting everywhere and very, very rapidly, and you have thousands and thousands of people who are being infected, then you may have more risk tolerance than we have in Vermont, where we've done such a good job.
I think that's it for questions on quarantine. Thank you.
So let's talk about the infectious period if you have COVID. So the infectious period is the time when someone with COVID has a high chance of spreading the virus to other people. And the infectious period starts 2 days before symptoms begin. And again, there's some wussiness in this. So the infectious period is considered to start 2 days before any symptoms begin, or if you have COVID and you have no symptoms, 2 days before you got tested. And there's a lot of wussiness in there. And then continues until what is considered to be recovery. And we're going to talk about recovery. So I freely admit, it's one thing to say, you know, I feel horrible, I've got a headache, I've got body aches, I was infectious 2 days ago. And that's true, by the way, for other viruses. This is not just specific for COVID. Other viruses, you're usually contagious 48 hours before you have symptoms. So it's true for the flu, it's true for other coronaviruses, which cause the common cold, it's true for a lot of stuff. So we aren't singling COVID out here. So that infectious period, it's fine if you feel crappy and you're like, okay, I've been sick for 2 days. But what do you mean I have no symptoms? Somebody tested me and now you're going to say 2 days. Isn't that random? The answer is yes, it's random. That's just the decision they made. And that's kind of the parameters they had to put around it, because it's anybody's guess. If you test positive with a PCR test, you have no symptoms. When you actually became positive, nobody knows. So they just picked the 2 days to keep it consistent. So if it doesn't make sense, you're not crazy. So let's talk about, what does recovery mean? Well, if you've had symptoms, you can leave home and be with others after 3 things have happened. And I pulled these straight off the Vermont Department of Health website. I'm actually going to do them in reverse order. I apologize. I probably should have flipped them. So the most important thing is the last bullet. It has to have been 10 days. If you have symptoms and you feel lousy and it's less than 10 days, wait the full 10 days, because it has to be the full 10 days to not be contagious. Then, in addition to at least 10 days, you have to have no fever for at least 24 hours without the use of any medicine that reduces fevers, and your other symptoms have to have improved. Your cough has to improve, your shortness of breath has to improve, your body aches have to be gone, your headache has to be gone. You know, some people are fatigued for a long time, but all those other symptoms really do need to be improved before you can be considered to be in recovery. Now, for some people, if you are immune suppressed, you're on medications for transplants or other things, you're on something for rheumatoid arthritis, you need to talk to your healthcare provider about when you are no longer contagious, because this is for people with normal immune systems and normal illness. But there are multiple examples of people who continue to test positive for weeks and weeks because they're on immunosuppressants. So this is the standard guideline on the Vermont Department of Health website. But if your healthcare provider says something different, talk to them, because everybody's medical condition is different. And then also, what if you have no symptoms? What if you're asymptomatic and you got picked up on a test? There was a screening test done, because you're in the healthcare field, or because you came home and it was 7 days and you got tested and you were positive. If you had no symptoms, you can leave home and be with others 10 days after the test, the date you had your positive test. Again, unless your doctor tells you different. So again, it's a little wussy for people who have, it's a little wishy-washy for people who've had no symptoms. We use the same criteria, and they seem to be working, but they are slightly more random. Again, if they don't make sense, that's why. So John, questions there before we go on to vaccines? And I realize I'm running over. I knew this was going to be long, so I apologize. But
that's all right. I think, yes, let's keep our eye on the clock. We got about 9 minutes to go. I think a preemptive question on vaccines that you can address which is someone thinks about our flu shot. And the reality is many of us get a flu shot every year, but the flu always comes back. It's not like we get rid of the flu. How will the COVID vaccine sort of be different than that, or how do we hope it would be different than that? So
you're right. How do we hope it will be different? So that's a really good question, and we should talk about that, because that is challenging. Let's review the vaccine very quickly, what we know and what we don't know, and then remind me, because I want to answer that question, because it's an important thing to understand about vaccines, how they work, how they work, and when they work 100% and when they don't work 100%, but why they're still important. So this is a brand new type of vaccine, but the technology has been around for more than a decade. This is an mRNA vaccine. It takes advantage of the processes that the body already uses to fight off the virus. The technology is new. It's never been used in a vaccine before, but it's been studied for more than a decade. Part of why they rolled this vaccine out as fast as they did is because they'd already done 10 years of work on this technology. So if they had to start from scratch, we would not be staring down a vaccine right now. But because this has been in the pipeline as a possible vaccine against viruses, and also as a possible vaccine technology against cancer, that's why the vaccine was able to be rolled out so fast. Very importantly, the mRNA vaccines, and the mRNA vaccines are the Pfizer vaccine and the Moderna vaccine, they do not contain a live virus. You cannot catch COVID-19 from the vaccine. And the mRNA, which is reproductive material from the virus, never enters the nucleus of the cell. It does not affect or interact with a person's DNA. So you will hear that going around, well, I don't want an RNA virus, it's going to change my genetic makeup. No, it's not going to do that. And I'll show you why not. So here's the mechanism. This is from the CDC slides. This is hot off the press. I got this yesterday from the CDC. What happens is that the RNA from the virus is taken out just for the spike protein. It is put into a lipid, which is a fatty little globule that is then injected, and it's taken up by the cells in your body that fight off infection. And those cells in your body treat it as though it's the actual virus, even though it's just a piece of the virus. And what they do is their normal process. What you see here is the normal process that your body goes through, except that it does it with the whole virus. And in this case, it's just doing it with a piece of it. It takes that RNA, it takes the protein, it turns them into proteins, and then it expresses them on the surface of the cell, and the body comes along and says, I don't recognize that, I'm going to fight it off. This is the normal process that your body uses to fight off an infection. So what they're doing, this is a very clever vaccine technology, what they're doing with this is they are very specifically making the body recognize this RNA and using it to exploit the body's natural mechanism for fighting off viruses to make you immune. So it's a very, very clever system. But as you can see here, under the RNA vaccine, if you follow it through, it never enters the nucleus of the cell. This is the RNA vaccine. A couple of things about the rollout, and I'll move fairly quickly through this, and then I will answer that question about the flu vaccine. So the first doses have arrived this week. The amounts are very limited. We're getting 3,900 doses approximately for the first round in 2 batches. The Moderna vaccine should be approved Friday by the FDA as well, and so that will add vaccine to the pipeline. But this is going to take a lot of time. Even in Vermont, there's a lot of people. There's not a lot of vaccine. It's going to take months. And so patience is required, and the ability to continue to, cleave to all of these guidelines. We can see the light at the end of the tunnel, but for a lot of us, it's really far away still. Phase 1 is the jumpstart phase, high-risk health workers, first responders, and then people living in nursing homes or people with major underlying conditions. When the Vermont COVID-19 Implementation Advisory Committee did the math, they found that there were 59,000 individuals in Vermont who are considered frontline healthcare workers. And these folks are going to be first in line for this vaccine. Those of us who are no longer practicing are not in this line. So these are the people who are first in line, along with residents of long-term care facilities. And they are looking at healthcare workers who are likely to be exposed or to treat COVID-19 patients. So these are who they're prioritizing: long-term care facility residents and staff, clinical support and support staff with patient contact. And so they are, and it's important to recognize this is not just doctors and nurses. The people who clean the ICU are probably more at risk, and they also are first in line for the vaccine. So janitorial staff, cleaning staff, individuals who work in emergency rooms and intensive care units are first in line, and first responders, emergency medical personnel with patient contact. So this is who's going to be coming in first. Phase 2 is K-12 teachers, school staff, childcare workers, critical workers in high-risk setting, people with comorbid and underlying conditions at moderate risk, homeless shelters, group homes, jails, detention centers. Phase 3 then gets to young adults, children, and phase 4 is everybody we didn't catch the first time. So let me answer. I know I ran through that very quickly. That is all available on the Department of Health website. Let me answer the flu vaccine question. So the answer is that not all vaccines are perfect, and the flu is particularly interesting because the flu changes every single year. So we vaccinate pretty effectively to the strains of flu that we think are coming, but the flu is a shapeshifter. And it changes every year. And so every year you have to tweak the vaccine. And sometimes you get it right, and sometimes you get it wrong. And it's not 100%. So the flu vaccine is 60% effective. However, what it is effective against is keeping you from dying from the flu. And that is really important to recognize, is that not all vaccines are 100%. Some vaccines, I'm going to go ahead and stop sharing my screen here. Some vaccines are 98% effective. Other vaccines are only 60% effective, like the flu vaccine. But it's better than nothing. You are less likely to be hospitalized from the flu. You are less likely to die of the flu. And most importantly, you are less likely to pass it on to someone who then may go on to die of the flu. And that, to me, is the most important part of the flu vaccine. And I'll give you the example. We know that there is a direct linear relationship between the number of children under the age of 5 that we can vaccinate for the flu and the number of adults over 65 who die of the flu. The more kids under 5 we vaccinate, the fewer adults over 65 die. And the reason is that children are little petri dishes and they infect their grandparents, right? So if you can vaccinate adults, if you can vaccinate children, you can decrease the number of grandparents who die of the flu. And so even though it's not 100%, that's why we do it.
I see a quick question here. Can someone with the vaccine still pass along the virus? Oh, I heard Dr. Levine answer this one today. Do you understand that question, Dr. Mcintosh? If you've had the vaccine, can you still spread the virus? Uh-oh. I think we might have a frozen right at 4:29. We might have a frozen Dr. Mcintosh. Can folks can hear me? I'm assuming. Thumbs up if you can hear me. Oh no, I'm frozen.